Hi, this is Musa Kiani from the University of Miami JFK Hospital. And today, with Owen Clenahan, I'll be talking about a very interesting topic for both hematologists as well as internists of bugs and Bruton's infection risks in BTKi therapy. Bruton's tyrosine kinase inhibitors, or BTKis, have transformed the treatment of B cell malignancies, including CLL and mantle cell lymphoma. These targeted therapies provide sustained disease control and remain quite effective in patients even when they harbor high risk genomic features, such as TP53 mutations. Their use has improved survival and the quality of life of our patients, establishing BTKi agents as a standard frontline and relapse therapy. However, by impairing innate and adaptive immunity, BTKi agents increase our susceptibility to infections, especially in those who are older or heavily pretreated patients. Most evidence comes from individual trials, highlighting the need for pooled analysis to better define this infectious risk for the treating physician. To that end, we conducted a retrospective literature review of clinical trials and cohort studies that had reported infectious outcomes in patients treated with BTKi agents. We used PubMed to search from 2013, which is the year that these agents received FDA approval, through the end of July 2025, using BTKi and infection-related terms. Of the 72 identified studies, 37 met our inclusion criteria. Eventually, data was extracted, including for malignancy type, BTKi agent, co-therapies such as other chemoimmunotherapy agents, infection incidence, infection-related mortality, and antimicrobial prophylaxis strategies. Outcomes were summarized descriptively, with regression performed to identify the predictors of infection-related mortality, which were then reported as odds ratios with a 95% confidence interval and p-values. Our results were as follows. Among the 5,486 BTKi treated patients, approximately 52% experienced infectious complications, commonly upper respiratory tract infection or URTI in about 18.7% of patients, pneumonia in almost 8%, and UTIs or urinary tract infections in 6.4% of all patients. Unfortunately, 150 of these patients died from their infections, most commonly from pneumonia, COVID-19, and invasive aspergillosis. Regression models revealed that ibrutinib and zenibrutinib were associated with modest, though not statistically significant, increases in mortality. Neutropenia was frequently seen, with higher crude mortality noted in patients who had neutropenia versus those that did not. However, neither neutropenia nor the use of antimicrobial prophylaxis could independently predict infection-related death. In conclusion, our pool analysis showed that while infection-related mortality in BTKi-treated patients was low, risks vary by both agent and underlying disease. Infections included bacteria, virus, and fungal pathogens, with many opportunistic cases typical of immunocompromised hosts also seen quite frequently in these studies. These findings emphasize that we should tailor infection monitoring and antimicrobial prophylaxis to both the BTKi agent and the disease context rather than applying uniform regimens. Physicians who prescribe or manage patients, such as hematologists as well as some internal physicians, should be mindful of these infectious complications. Thank you for listening in.